Good morning, everyone, and we are starting the second day of our annual Advanced Interventional Cardiology course. My name is Dr. Sanam Khowaja, and I'm Chief Fellow Interventional Cardiology. The talk today given to me is about the calcified lesions, the rock hard lesions, and the plaque modification. So I have no disclosures for this talk, and we will divide this talk in three different parts. In the first part of the talk, we will be talking about the identification and the quantification of coronary calcium. We will move to the tools that are used for the modification of the calcium, and then we will talk about rotablation. What are your thoughts? What's going on here in this angiogram? Can anybody quickly just give a quick comment on it? Most of you might think that this may be an intraluminal defect, which could be a thrombus, or some of you might think that this could be any other differential of the intraluminal thrombus. And what to do next in this case? Obviously, we will wire, and then after wire, what would be our ultimate strategy? So we did an IVUS on this, and that shows that there is a severe calcification in that lesion. However, angiographically, if you see that it doesn't give a strong evidence of the calcium. Let's come to the second case. The second case is about an 81-year-old male who underwent PCI for an extensively calcified lesion. The lesion preparation was done with the scoring balloon and with the cutting balloons, and then DAS was implanted. Despite severe high pressure NC balloon inflation, the stent looked undeployed and adequate post-dilatation was not achieved. So if you see the blue cursor on the right of my screen, that exactly shows the area which correlates with the OCT image, which is at the bottom of this slide. So in the middle of the stent, there was a severely reduced luminal area with the MLA of 1.72. So how frequent are the calcified lesions? We in our daily practice, we very much underestimate the coronary calcified lesion. Calcified coronary lesions are found on 30% of all the angiogram we do, and 10% of all the PCIs which we perform. The biggest data we have till today is from the Syntax trial, which have actually seen the complex patients, and that actually tell us that around 50% of the patient that you are doing for the PCI, and around 54% of the patient, they actually had a severely calcified lesion. So now the second question is how to see the coronary calcification. We all see the coronary calcification in our daily practice on angiogram, we see it on IVUS, we see on ACT. We will quickly talk about that, how we quantify that calcium, and then based on that, we will decide that how we are going to deal with that calcium. So on angiographically, the coronary calcium could be considered as moderate and severe based on we see calcium only during the cardiac motion, and if we see only during the injection, then this is the moderate calcium, and if you see on a still image and it's on the both sides of the coronary vessel, it's known as the severe calcification. By the way, this picture shows two different devices. One is the Edward sapien valve in a TAVR patient, and an EPD in a SVG graft. So next is the IVUS. We have talked a lot about IVUS, so I will not go into the depth of it. So IVUS has a resolution of 150 to 200, but IVUS has a limitation. It could not see beyond the calcium. There is an echo dropout just at the back of the superficial calcium, so IVUS could not see beyond it. IVUS cannot only tell us about the thickness of the calcium, but it is an excellent tool to tell us about the length. It is also tell us about the arc of the calcium. One single point which I would like to make here is that superficial calcium is always nasty and more difficult to deal than the deep calcium. So a lot of scores have been proposed based on the IVUS for the calcium, but the important one to discuss here is the IVUS calcium score 4 elements we see on the IVUS calcium score on the IVUS. The first one, we see 3-quadrant calcium, which should be greater than 5 mm in thickness. Then you give it 1 point. If it is a 360-degree calcium, you give it a 1 point. And if there is a calcium nodule visible on the IVUS, you give 1 point. And then, of course, the vessel diameter, which is less than 3.5. It's any score that is above 2 or 3, then you straight away go for the atherectomy rather than trying other tools for the coronary calcification. So unlike the IVUS we talked about, OCT is an excellent tool. It does not have a limitation that it could not see beyond the superficial calcium. So OCT can see the deep calcium as well. And of course, OCT has an additional benefit that it could see the calcium yielding when we are putting in a stent. So it could tell us that how the stent has been expanded in the presence of calcium. As I've told you that even if the arc is less than 90 degree on OCT and the calcium area, it told us about the calcium area that it was less than 1.58. So as we talked about the score on the IVUS, OCT has also a calcium score, and based on that we divide it the severe calcification. The CVI score is the recognized score for the OCT calcium classification. We see 3 things: the angle of the calcium, the thickness of the calcium, and the length of the calcium. So any angle of the calcium which is greater than 180, it's given 2 points. The thickness is given 5. More than 5 mm is given 1 point, and the length is given 1 point. So now most of you will think about that IVUS is good and OCT is also good. Then which one is the best? So there was a study which was recently published, not recently, in 2017, which compared the IVUS versus OCT in the calcium, and it shows that the IVUS is more sensitive to pick up overall calcium and and if you could see that 364 patients out of 440 were picked up on the IVUS, whereas 338 on OCT. So why we are doing such a big debate on coronary calcification? What's the problem? The point is that coronary calcification is not only causing the problem in the stent deployment, the inadequate deployment, the inadequate delivery, and then of course the complication all are increased. So whenever we have a calcium, we have problem with stent expansion, delivery. We have increased rates of complication, which include the perforation, dissections, and then of course the increased rate of the post effects, the restenosis and the thrombosis. So a good plaque modification, excellent preparation of a calcium bed is an art for an interventional cardiologist. So now we will talk about the second part of my talk, that would be that how to deal with this calcification. Many of tools are available: NC balloons, cutting balloons, angiosculpt, opium balloons, scoring balloons, laser, rotational atherectomy. Anything left? Yes, the most recent one, that's the IVL. So these all are used for the calcification. We will not go into the detail of each one because we are in the short of time. So we will directly come to how we approach a calcified lesion and how we should approach the calcified lesion in our daily practice. This is a chart from the guideline which said that the first and important thing when approaching a calcified lesion is you should see that whether the guide wire is crossed or not, or you are able to deliver a balloon or not. If you are not able to deliver a balloon, then obviously you need a help with the delivery of the inventory first, and you need to use the microcatheter and guide catheter, which is on the left of this picture. But if you are able to pass the balloon first, you do a pre-dilatation, and then you go on all the classification of calcium algorithm, which we talked about right now. If calcium arc is greater than 180, If the length is greater than 5 mm, if the thickness is greater than 5 mm, that is all the CVI score and the IVS score we talked about right now. And any one of them which show the severity of the calcium, you should directly go for atherectomy in those patients. However, if any of these is absent, then you can go step up with the conventional tools, doing an NC, moving to the cutting balloon, and then the opium balloon. So that's a general overview how to approach. So we talked about till now that how we deal with the severe calcification. We take a guide catheter. Then if we are unable to deliver, we could take the microcatheter. We use guide extension. And then on the lesion preparation, we talk about that what we can do, like balloon balloon angioplasty and then orbital atherectomy. So now I will just talk about two modalities which are important and peculiar to mention here. ALCA is a modality with which we use a multi-fiber catheter, and the mechanism of burning is photochemical, photothermal, and photomechanical effect, most likely used in the angulated and the long lesions. Next is the angiosculpt scoring balloon. Many of our presenters shown them yesterday. Excuse me. Thank you. So there are three semi-compliant balloon. It's basically a triangular, and it has some cutting semi-compliant balloon attached to it, and they are usually used in the restenosis and ISR when there is severe calcification. Now let's come to the third part of my talk today, which is rotablation. So rotablation was first invented or discovered by Davidoff in 1980, and the first human rotablation was performed in 1988 by Fourier. So initially it was thought that rotablation is an excellent tool because it decreases the plaque burden and of course increases the minimal luminal area, and thus it decreases the rate of restenosis and decreases the mortality. But all of the trials, DARTS, STARTUS, ROTAX, and PROCAL, they didn't show any mortality benefit of the rotablation. However, they shows that rotablation can decrease the risk of restenosis, which can reduce overall outcome. So rotablation, just a quick review. Rotablation is 2A in a heavily calcified lesions in 2014 guidelines, but now in 2018 it is considered to be, it can be considered in the undilated lesions. So how rota works, it does not work on the elastic tissue. That's why rota cannot burr up or burn up our normal arteries. It can only work on the inelastic and the calcified plaque. How it basically do that? It has a burr which is a which has a diamond coated 0.5 micron attachings, and it do through that. So, insight into the rota, what basically the rota ablation look like. So we have a rota wire, which is a olive-shaped wire. It is 0.014 wire, and it has an olive-shaped end, which is 30 centimeter. And we take a rota bar over it, and which is diamond coated. As we talked that it has 0.5 micron edges, which is basically crippled, which burn the calcium through the packing movement. And then we have a drive shaft and a sheath which is attached to actually the connector. We also have a rota stiff wire, which we all should know, and it's only used whenever we need the support. So what is the best strategy to do a rota ablation? Always use a single bar or the minimal number of bar that are required, and always take a burr to artery ratio definitely less than 0.7. It could be 0.5, it could be 0.6. So rotational speed should be between 140 to 180 with the avoidance of the deceleration of greater than 5,000. And a gradual burr involves involvement with pecking, which is a to and fro movement, and that should be a short run and then taken back. So whenever we take rota on the table, we should do 3 or 4 things. Number one, we should check, we should drip that flush, and then we check the pedal which we have, keeping on both the Dynaglide and the rota ablation, and checking up the speed, taking maximum, and at the same time checking the deceleration that it should be less than 5,000. So if the deceleration is more, we should immediately check the gas and know and everything that it's working particularly okay or not. So when to do a rota ablation? That's very important, because it's a procedure which come up with a lot of bad ends as well. So rota ablation is only indicated when we have a functionally significant artery. By functionally significant, we mean that the stenosis is greater than 70%. We have a objective evidence of ischemia. The FFR is less than 0.8. And then if any of the above thing is present, then we should see that the patient is not complex enough to be a candidate for the CABG. So if the patient is not a candidate for the CABG, then we can attempt the PCI for that patient. And then, of course, we will go back to our algorithm, which we discussed in the beginning. It's mild, moderate, or severe, and then we decide our strategy according to that. If the CVI score is 2, we'll move directly to the atherectomy, and if it's anything milder than the conventional tools, of course. So always arterial access for the rota ablation is challenged, because the internal diameter of the guide and the burr has to have a adequate internal diameter to accommodate that burr. So this is a chart of the recommendation that a 6 French guide catheter can accommodate up to 1.5 or 1.75 rota burr, whereas a 7 French can accommodate 2.25 of the rota burr, whereas 8 French can accommodate up to 2.5. So when not to do a rota ablation? So there are 5 absolute contraindication for the rota ablation, and there are few relative contraindication for the rota ablation. So occlusion through which the guide wires are not passed is an absolute contraindication for the rota ablation. When the patient has a single surviving artery, we cannot do a rota ablation. When there is a severe LV dysfunction in that patient, it's an absolute contraindication. Rota is contraindicated in the SVG grafts. If you see angiographically evidence of any dissection or any thrombus, then you cannot proceed toward rota ablation. So as we talked about, that there are few procedural and technical difficulties which we face in rota ablation, and these are of course the relative contraindication. If a patient is having a severely angulated lesion, so then patient is having shock, or so we have other modalities which we use in these cases, like when patient is unstable, the orbital atherectomy is prepared. When we are a slightly angulated lesion, we can take the angiosculpt. And then of course, if the patient have a very long lesion length, it's greater than 25 mm, then it's one of the relative contraindication. So we've talked about everything almost. Now we will just talk about what are the complications that rota ablation got. So it's a bulky device. It causes 3 main things. It may cause the vasoconstriction, it can cause the mechanical obstruction, and it can cause the thrombosis. So whenever it causes the vasoconstriction, it leads to the spasm of the vessel. That's why whenever we do rota, we always give adequate nitrates to make sure that there is adequate vasodilation is achieved. And then distal embolization due to the mechanical obstruction. That's why whenever we do rota, we always load patient adequately, and there is enough data that whenever you are going for the rota ablation, you should load the patient with the ticagrel or as compared to that of the clopidogrel. And then of course the thrombosis, which would be possible. So again, when we are doing rotablation, I already made this point that there are few settings where rotablation cannot work, and then of course at that in that settings we have other things like orbital atherectomy that we can use. So important clinical edges for this presentation is that whenever you're doing rotablation, few things we should keep in our mind, that we should be adequately loaded with all the inventories. Like we should have a surgical backup, we should have the graft master, we have the support wires on our table. Usually, sometimes the rota bar is stuck. So, whenever a rota bar is stuck, we should, the first step we should do is passing a second wire. And after passing a second wire, there are two options. We can either cut the sheet and pull back that rota ablation into the same, or either we can cross up the second balloon and then we will remove that rota bar. So, just 2-3 concluding points. Coronary calcium is becoming more and more prevalent in the modern era. Aging population, because of the aging population, we have downstream presentations. And then, of course, there is short-term sufferings and the long-term outcomes. So 1 ounce of prevention is worth a pound of care. So before doing any calcified lesion, if we prepare it adequately, we would be able to deal it very meticulously. Thank you very much.